I'm Dr. Rebecca Lewis. I'm an audiologist and the audiology director of the Adult and Pediatric Cochlear Implant Program at Pacific Neuroscience Institute. A cochlear implant is very different than a hearing aid. A hearing aid amplifies sound to an already damaged inner ear hearing system. And then when you get to the point where hearing aids no longer benefit your ability to understand speech, you would come for a cochlear implant evaluation. A cochlear implant bypasses the damaged inner ear structures and stimulates the auditory nerve directly, which sends the signal to the brain, and the brain interprets it as speech and music. So the cochlear implant actually has two parts. It has an external piece, which is called the speech processor. It has microphones that pick up the sound. The speech processor digitizes the sound and sends it across the skin to the implant. So the implant has a receiver stimulator that's placed just underneath the skin, sort of above the ear, and then that collects the signal, changes it to an electrical signal that stimulates the electrodes that are threaded into the cochlea. And then instead of damaged hair cells sending the signal to the nerve, we have electrodes sending the signal to the auditory nerve, and then the brain learns how to interpret that new signal as speech and music. And so a cochlear implant is not a quick fix, it's a process. I kind of compare it to a knee replacement. After you get that sort of surgery, you have rehab. Same thing with a cochlear implant. The first day sounds the worst, and then it starts to sound better and better every time you come in to see the audiologist, and with patience and practice. If you're an adult that has tried hearing aids and you're still struggling to communicate on the phone, in noise, in social situations, at work, then it's a good idea to just come in for an evaluation so we can assess where you are at this point in time. It doesn't mean you have to move forward with the surgery, but we can get a really good picture in time of to assess your communication needs. Patients who are cochlear implant candidates sometimes suffer from a sudden hearing loss, and in those cases we want to treat them as quickly as possible. Other patients might have an asymmetric hearing loss or be a hybrid candidate, which means they have normal low frequencies, but hearing aids don't do them any good because the high frequency range of hearing is so poor that there's a lot of distortion when they hear speech. So our surgeon would use atraumatic surgical techniques to preserve the low frequencies so they actually get acoustic hearing and electric hearing in the same ear. And then we can always continue to use a hearing aid in the opposite ear of the cochlear implant and become a bimodal candidate. One question that sometimes families ask is, especially with young children when they get a cochlear implant, is will they grow out of their cochlear implant if they get it when they're a baby? And the answer is no. Your inner ear structures are actually adult size at 12-week gestation. That's why babies can hear their mother's voice in utero. So when you get your cochlear implant when you're really small, you don't need to worry about changing out the implant as you get older. Another nice thing that the cochlear implant manufacturers have done is that while there have been great advancements in technology on the external processors, you can benefit from that advancements in technology without surgery. So they always make them backwards compatible to the older internal devices. So patients years ago that used to have to wear a body-worn processor, so literally something that they'd have to wear in like a pocket or in a harness that they put on underneath their shirt with a coil that goes up to their head. Now they can just wear these smaller on-the-ear processors without having another surgery. When children are a candidate for a cochlear implant, we always support the family in choosing whichever communication modality they feel most comfortable with. So we will support the family if they choose American Sign Language, or if they want their child to have access to spoken language and audition, we will support that as well. And for every month that a child's access to hearing is delayed, that directly correlates to significant delays in speech and language development compared to their normal hearing peers. So the number one prognostic indicator of how well a child will do with a cochlear implant, or even with hearing aids, is how early they get access to sound. So time is definitely of the essence when we talk about pediatric hearing healthcare.